And so it has such implications that I think that people underestimate. I think they think the ketones themselves are just starving the cancer, but it's doing so much more.
Welcome back to the Health Longevity Secrets Show, where we push the limits of human potential and unlock the secrets to our health and longevity with your host, Dr. Robert Lovkin.
What if cancer isn't a genetic accident, but a terrain problem that you can influence? Today, Dr. Nasha Winters, a former terminal patient turned clinician, shows how ketosis, mitochondrial signaling, and smart off-label stacks can amplify standard care, cut side effects, and bend the curve on cancer outcomes. Plus, the radical center she's building to prove it.
And now, please enjoy this week's episode.
Hey, Nasha, welcome to the program.
What an absolute honor. I've been following you and your work for so long. I'm just very excited about being here with a conversation with you today.
Well, likewise. The feeling is mutual. I mean, I'm really amazed we haven't met before this. I really enjoyed your book. It came out a few years ago. It's still very relevant. I recommend it to everyone. And you know, the work you're doing now. I just gotta fix the Zoom here, but. The work you're doing is exciting. I can't wait to dive into metabolic, oncology, and everything around that. But before we do that, though, maybe just take a moment and tell us a little bit about your journey and how you came to be so passionate about this fascinating area.
Oh, thanks, Doc. Well, I mean, I think a lot of folks don't get into the oncology space unless they've had a personal story. And so mine is no different from that. At the ripe age of 19, shortly thereafter to be 20, I was diagnosed with terminal ovarian cancer. And unfortunately, it had been missed because my other collection of metabolic diseases, polycystic ovarian syndrome, endometriosis, cystic acne, even IBS, anxiety disorder, all of these patterns I'd had going on for many years. So they just thought it was more of the same when my symptoms started to get worse. I was in college, I was in pre-med, it was very stressful. I was working multiple jobs, I was working grave shifts. So they just thought it was the new stress environment causing worsening of my symptoms until I landed in the emergency room and I had a different doctor with a different perspective who dug a little deeper and unfortunately found out that I was on my way out of this world, to the point where there was nothing they could do from standard of care. I had 100% bowel blockage. I had metastasis throughout my entire abdomen into my liver. I had fluid buildup in my abdomen, in my lungs, around my heart. I had a grapefruit size tumor on my right ovary, and I had lymph nodes throughout my whole pelvic cavity, just loaded with cancer. And it had clearly been brewing for a while, but it had been masked by a lot of other conditions that I'd been carrying my entire life at that time. So that expectation was not that I was going to fight it or live it or battle it or survive it. I just simply wanted to understand it. I'd always been a pretty curious person. And that's what's led me on this almost, I mean, at the time of this conversation, I am just shy of 34 years out from that dreadful day or group of days. And I'm still learning. Here we are today, all these years later, still learning the why of my process and still weren't learning the why of other people's process.
Yeah, it's so fascinating how many of us, myself included, in this space were sort of compelled, drawn into it like you were out of personal reasons that made us begin to question the narrative that's still out there, you know.
Yeah, but you'd think 3+ decades later, we'd be a little further. In some ways we are, but in many other ways we are not. Yeah.
Yeah, totally, totally. Well, I'm so excited to get into this. I mean, your work. One of the themes of your work is that cancer is an ecologic disease of the terrain. Can you just like in a few words summarize kind of the terrain theory and what people can take home from that?
I mean, my gosh, I mean, we've been treating cancer as a genetic disease basically since 1914. There was a little moment in there from 1920s where Dr. Otto Warburg came in and broke up that construct a bit, and that lingered for a good 25, 30 years until we found the DNA helix, and we kind of jumped back into the somatic mutation camp. But ultimately, we treat this like it's a genetic accident, like it's a genetic mismatch, that there's nothing that we can do about it, that it's simply bad luck, and we are disempowered sitting ducks. That is how we've been presenting cancer for decades now. That's how our research is focused. That's how our treatments are focused. That's where our funding goes. And so what we've learned, and in fact, I believe, you could correct me on this, I believe in November 2024, Nature came out with an article suggesting that the somatic mutation theory is finally laid to rest. Now, how does that translate into day by day? Maybe we won't see that still for a while as standard of care, but at least now the sort of consensus is in that perhaps the genetic doesn't start there. Perhaps there's an upstream effect. And that upstream effect found by people like Dr. Otto Warburg, later down the line, many years later, people like Dr. Mina Bissell, later even further, people like Dr. Tom Seyfried and Angela Popp and Dom D'Agostino and others started to realize perhaps the genome was under the protection of something higher up. And that is this metabolic mitochondrial, process, which is basically this energy exchange process that's doing a lot more than just creating energy. It's the surveillance, it's the intake of stimuli, it's the translation of that information, and it's the signaling of that information to the surrounding organelles, cytoplasm, cells, tissues, organs in this, big meat suit that we carry around. And yet we keep treating it like it starts at the genetic level, but it in fact starts upstream. And so that's probably the simplest way to describe that this is really more at the root, a mitochondrial metabolic disorder. And, Dr. Rob, you more than anybody know that people still hear the word metabolic and they immediately think, my metabolism is fast or slow. It's so much more than that. The metabolic aspect is literally how the ecosystem inside of us interfaces with everything on the ecosystem outside of us, and the signaling that it has, the communication it has with the entirety of the ecosystem. It's under the gut. It's under this powerful communication process. So there's also a lot of opportunities for communication to go terribly awry. And in the last, several hundred years or so, we've put in a lot more information into our bodies, a lot more data, a lot more stimuli, a lot more exposures of things that we've never been exposed to before. And our body is overwhelmed. And specifically our mitochondria are overwhelmed. And as such, they can kind of chug along and do their job appropriately until they can't. And that's what we're finding is likely the underpinning of many of the chronic illnesses that plague us today, from, of course, cancer, which is my area of expertise, but it could be diabetes, it could be mental illness, it could be obesity, it could be autism, it could be any of these collection of conditions that are now understood to be more mitochondrial and metabolic in nature rather than genetic in nature.
Yeah, it's amazing the revolution in our understanding in all these areas, and especially the focus on, as you say, metabolism, and especially the mitochondria. And today there are at least three companies now that are working on mitochondrial transplantation, as a treatment for so many things. And it just, the mitochondria, when I went to medical school, were kind of batteries, that was it. And they certainly do that, but they apparently do a lot more. One
Yeah.
of the, one of the hallmarks of metabolic therapy that you talk about, and we others have talked about on this program, is a ketogenic state achieved through nutrition. In other words, what is it about ketosis that is metabolically healthy or advantageous in general, and for cancer in particular?
First of all, I'm so grateful that you called it a ketogenic or ketone state versus a ketogenic diet. The ketogenic diet is one way to achieve ketosis, to achieve this natural physiologic state. So just really appreciate that you clarify that from the get-go, because my goodness, there's a lot of misinformation. There's probably more misinformation about ketosis than there is good information about it. And partially because it's relatively new in our discussion, despite the fact that it's been a therapeutic intervention since, for over 100 years, but, neither here nor there. But ultimately, ketone bodies are signaling molecules. Really simple. So when I talked about the role of the mitochondria, are they're taking in information, they're translating that information, and they're sending out signals to the rest of the body as to what to do with that information. One of their most powerful levers, the things that they can leverage the most are ketone bodies when they're present. And so I often like to explain to people that even as babies, when we're first born, we're in a state of ketosis. And as we're waiting for our mother's milk to come in, we go into an even deeper state. That's a survival mechanism. It's like, let's burn an alternative fuel source until we can get access to some fast carbs, right? Through the galactose of the mother's milk. And yet our desire from that moment is we kind of get our sweet tooth right from the get-go. And it's really difficult for us to want to go to anything but that after we have our first hit, if you will. And yet for many, many millennia, we were more seasonal of our access to easy carbs. And that has changed in modern times. It's now available to us 24/7 and in forms that our ecology have never seen in previous generations. And so now it's like we're extremely overfed and more undernourished, and it's more difficult to achieve that natural state of ketosis when we are in a state of lack in our energy resources in our body, because none of us ever kind of dip into that accidentally anymore. And so, I've been in practice long enough to know that anytime you suggest that someone caloric restricts or fasts or alters their diet in any way, it is a hot button controversial discussion. It really triggers people from all sides of this. And yet what I've learned is that ketone bodies, whether they are achieved in just a natural state of fasting, are achieved in carb restriction in general, or just carb minimization, or if they're achieved through an actually high fat, low carb diet, or even exogenous ketones, they are really powerful signaling agents to potentiate any other therapies and to have vast, like massive impact on change in the physiology, and in the microbiome and in the way we think and feel. And so I think they're this really underrated signaling agent that we could leverage much more readily in the medical field to make a lot more dense than many of the pharmaceuticals we have at our disposal.
And so clearly the ketogenic diet then will make us, sorry, the ketosis. No, being in ketosis, however we get there, will make us healthier. Their advantages are microbiome, our metabolism, our mitochondria. But there's evidence also that it actually can improve outcomes in cancer, right? There are some early studies now that we're beginning to see that, correct?
Correct. And even, I mean, my goodness, let's go all the way back. 1909, Dr. Moreshi, learned that just fasting was debulking tumors, so shrinking tumors. And we didn't know this then, but we can look back now and maybe assume that yes, you were starving some of the fuel sources for that cancer, but you were also eliciting ketone bodies, which pull other levers. It lowers inflammation, so it has direct impact on particular cytokines, which are inflammation is a big cancer proliferator, and a big proliferator of metastasis. So you want to lower that inflammation as much as possible. And here's a very valuable molecule that does that. It also regulates the insulin pathways, which, my gosh, studies show between 70 and 90% of all cancers are under direct go mode in the face of insulin and insulin growth factor. And so if you can turn down that volume, you really give yourself, some runway to get ahead of the curve of growth factors. It definitely lowers things like basoendothelial growth factor, which is a marker of angiogenesis. So we don't have a lot of tools in our toolbox in standard of care to address the vasculature that goes to feed tumors. And when we're in a fasted state and have ketone bodies, we redirect that blood flow elsewhere. We redirect those resources elsewhere. Those are just examples, but one of my favorite examples is even the direct impact of ketone body and their signaling potential on the vagus nerve. And there's so much, in fact, I just spoke at a medical conference on this very specific topic to 1,700 clinicians from around the globe on the research behind this, of which there is a ton. So it has a direct impact on what's happening in the microbiome, what's happening in neurotransmitter communication. It's downregulating the excitatory components in the brain. It's upregulating the feel-good components of the body. It's helping change behavior. It's helping change belief system. It's helping put the body into a state of rest versus run, so that the body can actually receive treatment and receive healing. And so it has such implications that I think that people underestimate. I think they think the ketones themselves are just starving the cancer, but it's doing so much more.
So if the evidence of preliminary evidence all the way back to 1904, and then certainly after your book came out, it literally in the last few years, there's just been growing evidence of the benefits of ketone, being in a state of ketosis as an augmentation for cancer therapy. I guess the question then becomes, what's the pushback? In other words, what do you think the issue is? Why isn't everybody doing this for, while cancer is so common, why aren't all cancer patients managed somehow metabolically, in addition to their other things? I mean, it's not an either or thing, correct? I mean, these are not exclusive. It doesn't diminish chemotherapy or surgery or radiation or standard treatment regimens, right?
Right. Well, in fact, the studies are really clear, and I've seen this clinically with thousands and thousands of patients. It actually potentiates those therapies and protects from the side effects. So it's definitely not, exclusive. It's not like just do the ketogenic diet. In fact, I would never recommend that. Like it's a tool to leverage other therapies, make other therapies work better. So from the conventional like chemotherapy and radiation to even the more unconventional, like hyperbaric oxygen and high dose IV vitamin C, for instance, like those are some ways that no, it's not mutually exclusive to the alternative space. To your question about why is this not more accepted or more mainstream, I have similar questions, but there's a few things. Number one, clinicians have what is that? I think the studies currently are less than 25% of medical schools have even an elective course offered in nutrition. And when you have a medical student who's going through med school, those elective courses are not something you jump to typically, unless you just have a very personal interest. So, and even that elective course is very, very limited. There's really no room in our training for this. You have to go off campus, if you will, to learn this type of medicine. Number two, I failed to mention in the signaling aspect of ketone bodies, when we look at the hallmarks of cancer, they went from 6 to 10 to now upwards of 14 and 16. Hanahan and his team just kind of keep building on it. And we keep looking for drugs to target those hallmarks. And the irony is that it hasn't changed our outcomes one iota, because no one's asking, well, why are those hallmarks expressing? But either way, when you look at a tool that absolutely targets each and every one of those hallmarks simultaneously, ketone bodies do just that. And so I believe that there's also a bit of pushback and maybe fear from pharma that there is something that is virtually free, that you can access through diet and lifestyle, that is far more potent to address those hallmarks than any of the pharmaceuticals on the market. So I believe there's industry pushback from that. And I've got good reasons for that. My husband worked for Merck Pharmaceutical. He was a RAS mutation expert, there was no interest in this. And guess what? One of the best treatments for targeting KRAS mutation is therapeutic ketones. And so it's like these are the places where the KRAS mutation pharmaceutical drugs are failing miserably. And so they don't really want you to know that there's a better therapy, just like when we were treating little kids in 1920s for epilepsy. Until the drug Depakote came out in the 40s, the diet, the therapeutic ketogenic diet, worked beautifully. But once the pharmaceuticals made it to the market, they never worked as well as the diet, but they quickly replaced the diet. And so that theme is playing out here. And part of that is because there's also a belief system from doctors. They lay their own beliefs on the patients. I will hear doctors say again and again, that's just too hard for them to do. That's too demanding. It's too difficult for the patient to do this. And I just want to like slap them upside the head and be like, let them make that decision. Don't make that decision for them. Don't impose your own sugar addiction behaviors on your patients, right? Because that's what they're doing. They are limiting the belief system and therefore limiting the opportunity that these patients have to become like sovereign, empowered individuals in having a hand in their own outcomes. And so I think that's the other one. So I think industry is frightened. I think people want the quick fix pill. And I think that people also limit the belief systems around it.
Yeah, I mean, so yeah, a very benign thing would be just ignorance and people aren't aware of it, and then more darker, pernicious influences from the pharmaceutical and other industries that, after all, medical education is largely paid for by pharmaceutical companies, so it really colors what, all of us get in our training. But I guess, you have to wonder, it's not just something that's nice to add to treatment. If you take like the glioblastoma papers and some of the other early work that's coming out, where people actually improve their outcomes and even survival on a keto approach, a ketogenic approach, versus the people who didn't get it. And these are, well-controlled trials. You can make the argument that it's actually life-saving for these people.
As a clinician who's got the boots on the ground with the patient and the clinician serving those patients, I hear people, I say, well, that's just anecdotal. That's anecdotal. But my gosh, doc, when you see thousands, if not tens of thousands, when does it move from anecdotal to fact? Because it's easily measurable. This isn't subjective, right? We have amazing tools like continuous glucose monitors and, blood stick like the Keto Mojo and others like that in the market to check for glucose and ketones in the blood, and GKI is the glucose ketone index. We have imaging. We have other labs. We're looking at the other metabolic fingerprints like lactose dehydrogenase and lactate pyruvate ratios. We're looking at organic acids profiles. We're looking at just even changes in uric acid and inflammatory markers. We have data upon data upon data, as well as patients' subjective experience of this, which the side effects are many, meaning calm, different mental clarity, resolution of other comorbidities, resolution of lifelong mental health issues. Those go along for the ride while we're also leveraging cancer treatments, And so I think it's just so ironic. And to your point, I think several years ago, I think 2018, Steve Reed brought out a paper with a lot of colleagues about that ketogenic diet should be standard of care with standard of care. And I've got a really dear friend who's come through my training, Dr. Chris Smith from Barrows, head of neurosurgery, well known for his work in glioblastoma. Has reported at dozens and dozens of neuro conferences. And even in his own backyard, despite the fact that his outcomes are better than his colleagues, by bringing in this tool, no one wants to hear it. No one wants to hear it. Like, we've lost famous people and senators and whatnot who literally in the same state where this is happening did not end up in Dr. Chris's camp, which is a bummer because could there have been different outcomes? We can't ever say for sure, but I can tell you clinically, I see the difference when someone brings it on who hadn't been on it. I see the difference when people jump off of it when they've been on it for a little while. And I know that you can definitely change the experience and the outcome measurably when you are adding this tool into the rest of your treatment protocol.
Yeah, we touched on exogenous ketones already. I mean, Dom D'Agostino was just on the program here. Which patients do you use them for, or what in general? What's the application for you in oncology?
So a lot of folks, I was a little nervous early on when the ketone bodies started, exogenous ketones started hitting the market because I was really afraid that people would default to like the easy button. That's our human nature. Like we're seeing a whole thing of that with GLP-1s and the whole bit here, which by the way, ketone bodies are GLP-1s. So just saying, they have that same impact. Just saying. Um, but I was worried that it would just be kind of abused. That people like I can still go and eat my crappy diet and my ultra processed foods and still, have my buckets of sugar and just take these. Well, you can, and yes, you get some benefit, but it doesn't have the same impact than if you're making them endogenously. But I certainly use them to enhance and also to help smooth the ride. And so, what I mean by that specifically is somebody who's not a fat burner, someone who's not a dual engine, a hybrid there, who's really new, especially if they've been very metabolically dysfunctional for a very long time. It can be a bumpy ride moving into that dual, that hybrid engine or into that fat burning state. And so it can cause a lot of people can hit that discomfort and bail, right? And instead of breaking through to the other side, a lot of them will bump up against that and fall back. So I have found that exogenous ketones can really enhance and help them achieve that state faster, to get into more of an adaptive state, a fat burning state, and it could smooth the ride of their discomfort and especially help with what's known as like the keto flu. So I love it for that for folks who are really struggling. I don't often offer that up front, but because I don't want everyone to lean on it. I want them to feel that they've empowered it themselves, but I definitely know it's a very powerful tool when it's needed, when they can't break through it on their own. And that's not a failure of them. We're all wired differently, that some people have some single nucleotide polymorphisms that may make it more challenging to become a fat burner. Some people may be on certain pharmaceuticals that may make it more challenging. So the exogenous ketones can really help override that, which is exciting. Where I also love to use exogenous ketones is to potentiate other therapies. So for me specifically, hyperbaric oxygen therapy, radiation therapy, as well. So what I do is I have a person in a therapy, either in a state of ketosis, so they've got some measurable ketones on their blood monitors, at least 1.5 and above is my preference for before you go into radiation or hyperbaric oxygen or even hyperthermia. And then if they're not quite achieving that on their own, then 20, 30 minutes prior to that intervention, we have them take a bump of ketones. 10 milligrams is typical of what we often offer for that. So we really strongly lower the glucose, strongly lower the insulin, and strongly up the ketones and get them more into a therapeutic state, closer to 3, 4, 5. And man, it potentiates the other therapies. It protects the healthy cells even more, and they recover even faster. And so those are some ways that I've used exogenous ketones in practice.
Yeah, and speaking of other adjuncts, just maybe like off-label stack triage. I mean, I've
Yes.
got a list here: metformin, statins, doxycycline, mebendazole,
Yep.
LDN, rapamycin.
All the stack.
Which have you found to be valuable, or
Ah,
all of them?
You know what? Time and place for each. We've learned, like, I love to look at pharmacogenomics. So a lot of people, everyone got super excited about metformin, but about 30% of the population have these SNPs, these single nucleotide polymorphism hiccups that make them, number one, not use that drug well and even have terrible side effects with it. Metformin across the board will damage methylation and will damage microbiome. So I don't want people to like lean on that as their way to lower insulin growth factor. But it definitely has a time and a place, and I use it kind of like a scalpel instead of like a sledgehammer into the system. Around this, if someone has a lot of history of autoimmunity or Th1 dominant patterns in their immune system, low dose naltrexone is one of my favorite tools to bring on board. It has direct impact on inducing apoptosis in many cell lines, but it also has a really powerful effect of modulating and enhancing the immune system. And it's also a really powerful tool to help bring on board either before or during someone is using a checkpoint inhibitor so they don't overshoot the desired effect. It really can dampen the excessive autoimmune process that happens in a lot of people taking the modern cancer immune therapies today. And then some of the other drugs like mebendazole and fenben, again, time and a place. I really like it if I can see in their labs that their monocytes, eosinophils, and basophils are all elevated. That often indicates a parasitic or a growth, a dysbiotic overgrowth. And I find that those patients with that sort of fingerprint in their labs do really well for a short course on the fenbens or the mebendazoles, even the ivermectins. But we have come to the point, gosh, in the last few months even, but over the last few years, we can actually test people's blood to see what off labels. And let me just preempt by saying there are tests that have said that they've been doing that for a very long time. And I will also carefully say that not all of these tests are created equal. My advice to the consumer would be to look for one that is FDA approved, third-party validated. Okay, so don't get caught up in the influencer side of things, because there are certain tests that say that say that they're doing this that I don't trust that they are. So I'll leave that unnamed. But there are tests that do offer third party validated FDA approved testing, not yet covered by insurance. So they're pricey. We're talking $4,000 to $6,000 out of pocket. But when people are spending, $3,000 a month on high dose IVC and all these off label drugs and maybe some hyperbaric oxygen, wouldn't you like to know if those are doing anything for you first? So to spend that up front, you are saving yourself literally tens of thousands of dollars down the line, and you're also seeing what are actionable targets for you in that moment. So we can actually look at various off-label drugs. We can look at various natural therapeutics. We can look at various sort of repurposed standard of care, chemotherapies. So we can even use standard of care chemotherapy in a unique way. We use it in a metronomic way that's acting more like an immune modulator than an oxidative, bomb in the body. So there's so many cool ways we can harness standard of care therapies better, but they need to be done so based on the individual and what their body is asking for, and not based on NCCN guidelines, which is the dictatorship of how we practice, which does not hold any reality of what's actually happening in a patient, which is really unfortunate because a lot of companies are doing these types of testing, even insurance covered ones like Foundation One, Caris, et cetera. But then they get that data and they still don't use it in practice. So they're still like, oh, you're still going to get what NCCN guidelines tells you to get, despite the NCCN guidelines not fitting what that patient's body's actually saying on the test would be a good target for them. So I'm seeing this again and again. Like, I'll give an example. Yesterday, I had a consultation with a doctor who's working with a patient who's about ready to go with Dr. Patrick Soon-Shiong's protocol. Really, I am one of his biggest cheerleaders out there doing Raise the Roof for him since 2014, when I first heard him on 60 Minutes talking about that we should stop calling it breast cancer or prostate cancer and start talking about pathways, instead of tumor sites. That I was so excited about that. The man was really speaking more about terrain than tumor. And then he's really ahead of the curve in understanding that the immune system really does need to be harnessed for this, but he also is still protocol based and everyone's getting the same approach. And what was really unfortunate is there was this patient who was about to spend almost $1 million, because this is an out-of-pocket treatment right now, and doesn't even have the PD-1 or the PD-L1 target. And yet everyone's like, well, we're just going to give it to you anyway. Well, the guy also has Hashimoto's autoimmune thyroiditis and Sjogren's syndrome. This is going to wreak holy havoc. He will wish for death with this. This is what happens in over 80% of patients who take these medications. And just because it's innovative and amazing doesn't mean it's for you. And it doesn't mean that you can't do that therapy, but you've got some work to do to be able to receive it in a different way. And so my job with helping this clinician help this patient is to because this patient's very, very much determined to do this treatment. So we have about 3 weeks to get him ready and hold our breath and, hope for the best. Because when it works well, it's a miracle. But when it doesn't, it can be a death sentence, and you have to be very careful. It's very little wiggle room between those two places. And I think we can do so much better for our patients. And you only hear about the good stories. You don't hear about the bad. And so I think that we can be more nuanced and more sophisticated with this approach that actually serves our patients better rather than our own agendas.
Well, given all the challenges that we've talked about in the guidelines you've mentioned, when you talk to conventional sort of mainstream oncologists who are skeptical, are there any particular data points you use to win them over, or what are your arguments?
Well, often, I mean, honestly, what I just kind of outlined for you here usually makes them go, wait, what? When we're talking the same language. And so I've learned that data is the equalizer. And so if I can say, well, let's look at their mutations, let's look at their molecular profile, let's look at their single nucleotide polymorphisms, their pharmacogenomics, let's look at their labs, their neutrophil to lymphocyte ratio, their markers of inflammation. I mean, a C-reactive protein is prognostic for whether this patient's even going to respond to this therapy. And so when I start to feed them back their own data and show them the studies that go with that data, my job is to say, you're the tumor expert, I'm the terrain expert. Let me help you and the patient get their terrain as ready as possible and as primed and resilient as possible to fully utilize your therapeutic to the best outcomes. And when they hear that and they realize we're on the same side, and I can literally make their job better and their patients' outcomes better by coming in with this terrain approach, it's a win-win for everybody. And then usually those are the doctors that end up taking my training program. They get through like some funny stories as early on when I would have patients hire me to do a consultation when I was still seeing patients, and they would hire the oncologist, and the oncologist would get on the phone and be like, oh, I don't even know why I'm here, but they paid for my hour and your hour, so let's just get this over with. 100% of the time, I probably did this 200 times. 100% of the time, never once did this not work out this way. They were like, this is amazing. Can I do this for other patients? When do I have a follow-up? And can I do this for myself? And so that's what happened, because they realized like there is so much misinformation out there. I understand why there's the alternative medicine camp and the conventional medicine camp. And maybe it's because I'm a Libra, I don't know, but I really believe that there is the best of both worlds that can be brought together for the good of the patient outcome.
The cancer and aging share many hallmarks, and aging is, one of for many cancers, the single greatest risk factor, among them. So, yeah. So what longevity levers do you use, if any, to meaningfully reduce cancer risk? Is that a part of the program, even rejuvenation? Because there's so much progress being made in this space now.
Well, first, I love that question. And I do want to say, we used to think of cancer as the disease of the elderly. When I was in medical school, the average age of a cancer patient was 68 years old. I believe I think it was 2015, that average age is now 48 years old. I'm imagining it's younger now because of just what I see in myself and the thousands of, over 1,000 clinicians across 46 countries that are feedbacking the same finding. But here's the thing. It's not because these people, it's like, oh, the young are now at risk. No. What I want people to understand, our age is dependent on the health and wealth of our mitochondria. Our mitochondria are our longevity. They are our chronology, they are our biography and our biology. They are the expression of our health. And so what's happening today, as I mentioned, our mitochondria are under more duress than ever before. And what that translates to simply is that our mitochondria are aging faster than we are chronologically. So that's what's happening, is you're seeing younger and younger people, but they have older and older mitochondria. Does that make sense? And so when you talk about the longevity world, a lot of people think of longevity like a little bit of something here, and a little tuck here. That's not longevity medicine. Longevity medicine is looking into the ways that we can actually extend those telomeres, that we can actually improve the health and wealth of our mitochondria and our mitochondrial function. And there are so many cool hacks around this. And probably the best, fastest, cheapest, most free is fasting.
Hmm.
And so I really love the whole longevity research world around the utility of fasting, intermittent fasting in particular, waves of fasting, longer fasting here and there is like a bigger punch. I mean, even Dr. Tom Seyfried and even Dr. Walter Longo said that, every one of us would do ourselves a huge favor of prevention of all cause mortality if we did a 5 to 10 day water fast twice a year, like just the amount that drops there. So I think that's one big hack. Another big hack is things like urolithin A. I'm really excited about some of those markers, or C60, the buckyball, things that are very big mitochondrial resuscitation nutrients, that are very, very powerful there. And of course, taking care of your environment, everything you're putting in, on, and around you really nurtures and fosters healthier mitochondria. Getting back into rhythm, knowing, getting back into rhythm of your circadian rhythm. Sleep is a very powerful, powerful anti-aging, remedy. Melatonin, something that, people like Dr. Russell Ryder, big researcher in this area, has done a ton of research that we all naturally lose our melatonin levels over our lifetime as we age, but we're losing them early. Again, it seems to go hand in hand with the age of the mitochondria. And so we used to worry that giving melatonin in high doses would replace our own body's production, but that's not the case. And Dr. Ryder has shown that over and over again. That's a really powerful sort of defense hack that I think that we can utilize as well. So those are some of like the ones, and then optimizing vitamin D. That's one that we've all been so taught to fear the sun, and we also use detergents on our skin. It takes 3 days to process, the vitamin D into our skin and absorb that. And if you don't have single nucleotide polymorphisms and you don't use detergent on your skin, you might be fine, but the majority of us are actually walking around with very low vitamin D levels unbeknownst to us, which is like between melatonin and vitamin D3, they can be very big protectors of the genome through mitochondrial mechanisms. And so there's a lot there. And I think that, fasting, I think, is still probably my favorite longevity hack that there is.
We're almost out of time here. I want to be respectful. Just a quick question. When you mention mitochondria, do you measure mitochondrial function or age directly, or is it more inferred through overall metabolic health?
Well, I've been doing the inference for some time, but we are starting to get more and more testing that allows us. The organic acids gives us some information. We can gather a bit. There's some new ones about ready to come out on the market this year, which I'm very excited about. Some of the longevity testing that's out there gives us some, but I'm not quite sure how reliable they are yet. So the jury's out. But this is something that we're actually doing in our nonprofit lab, Metabolic Training Institute Health Lab, is we're starting to actually test this. We want those answers ourselves. So we're looking at cell line studies. We're looking at cell respiration studies using a technology called the Seahorse, which is kind of like a modern day Warburg test, as well as metabolomics testing, because we really can start to get a better sense of how old or how robust or what kind of quality or quantity do we have in our mitochondria, and what therapeutic interventions make a difference. And so that's what we hope to answer from our laboratory environment.
In the last couple minutes, I'd love to hear about your project. We talked offline a little bit about so many exciting things you're working on. Maybe you could just share some of those
I'll keep it brief, Doc. So here we go.
Okay.
30 plus years ago, I started dreaming about needing a place where everything is under one roof. To save my own life, I had to literally travel all over the world. And with someone who had no resources, I literally traded for house cleaning in parts of the world just to get labs done, or, just did things like I worked in such unique ways to find resources to take care of myself. I knew that someday we needed to have the best of all worlds under one roof. There's a lot of places that say they have alternative or integrative medicine centers at big academic institutions, but I will tell you right now, those places are only putting lipstick on pigs. Okay. So that's really all it's doing. It's not actually integrated medicine. Yes, things like yoga and meditation are important and very good medicine, but do we need to be spending millions of dollars of research to say that? No, we do not. When I'm talking integrative medicine, I'm talking off-label drugs. I'm talking leveraging various tools that are vetted, curated tools from the alternative space that fit the patient individually. But I also need good testing, good imaging. I also need good, more direct interventions. Sometimes surgery is required. Sometimes radiation is required. Sometimes off-labels are required, chemotherapy, et cetera. That needs to all be done under one roof, because when we silo off all these practitioners, we fail the patient. Those patients can easily fall through the crack. We also need to make these therapies accessible by all, because the people to get access to this type of care have to have resources. And so that's one of the long-term plans. So I've had this vision of a residential hospital and research institute that's taking form in Southeast Arizona on an organic regenerative farm, because you look at some of the most toxic buildings on this planet, toxic building syndrome, hospitals are at the top of that. They're on campuses that are completely sprayed down with just, frankly, shit tons of glyphosate and pesticides. The food, they average $1.49 a day to feed patients in a hospital setting. That's not okay. These are not places where people will go to get well. I'm building a different model, a different system. We're building in the data platform for that. We're building in the education for that. We're building in a new model of research for that. And so honestly, I'm taking on a Goliath. I'm not just, I spent the first 20 years of my career trying to fix a broken system. That almost killed me multiple times over. So now I'm just going to build a new one. And I have a lot of people helping me do things like this around the world, maybe in seemingly unrelated fields, but we're all rowing in the same direction.
Wow, that's so exciting. And they can find you on your website and through social media. I follow you.
Oh,
All your great things, and your podcast also. But thanks so much, Nasha, for spending time with me today. This has been a lot of fun, and I'm looking forward to great things in the future, hearing more.
Can't wait. So honored to be here with you, Doc. And I can't wait to have you on Metabolic Matters. So we'll go there soon.
If you are enjoying this program, please hit that subscribe button, or even better, leave a review. Your support makes it possible for us to create the quality programming that we're continually striving for. Half of all heart attacks strike without warning. Your best early warning? A CT calcium scan. We've made it even better by adding arterial age and liver fat quantification, all from the same scan. Now available nationwide without a doctor's prescription. Use the code LUFKIN20 for 20% off. This episode is brought to you by L Nutra, maker of the Prolong fasting mimicking diet. Use the link in the show notes for 20% off.
One of the most common questions I get asked are which blood tests I check for myself on a regular basis. Well, I check up to 50 biomarkers, but the secret is that I'm able to do everything from the convenience of my home, and I collect a sample with this new breakthrough device. So no more trays full of tubes of blood, needles, or even finger sticks, and you don't need to be a doctor to do it. Then I just mail it in for the results. Cyfox Health makes it possible. Use the link below to get 20% off.
Can I start? Is it recording?
It's already recording.
Oh, sorry. This is for general information and educational purposes only, and it's not intended to constitute or substitute for medical advice or counseling, the practice of medicine, or the provision of healthcare, diagnosis, or treatment, or the creation of a physician-patient or clinical relationship. The use of this information is at their own user's risk. If you find this to be on the value, please hit that like button to subscribe to support the work that we do on this channel. And we take your suggestions and advice very seriously, so please let us know what you'd like to see on this channel. Thanks for watching, and we hope to see you next time. You should say that.
No, that's good. It's for you to say it. I think that's very good. Do you like it? You want to do it one more time, or is that good? I think that was good.
Yes.
All right.
You need to save the recording.